Our next speaker is Professor Rachelle Buchbinder, who is a rheumatologist and also a clinical researcher. She's an NHMRC Investigator Fellow and head of the Musculoskeletal Health and Wiser Healthcare Units at Monash. She's internationally known as a vocal proponent of evidence-based medicine, and she's done some really landmark studies examining how treatment gets into practice before it's been properly evaluated. She's written a really intriguing book that I want to go away and read called Hypocrisy: How Doctors Are Betraying Their Oath, written with an orthopaedic surgeon, which is highlighting the over-reliance on medicine, and she's written it for a general audience. So over to you, Rachelle.
Thank you very much. I would like to thank you for the privilege and honour of talking to you all. I want to acknowledge the Kaurna people on whose lands we are meeting today. So we've heard that climate is threatening human health, climate change, and you've also heard that healthcare is also harming the environment. And in fact, if healthcare was a country, it would be the 5th highest emitter of greenhouse gas emissions in the world. So we're doing really badly, and we need to urgently reverse that. This is data from countries where we have data on their carbon emissions, and at the top is the USA, who lead the world, and 8.5% of healthcare is responsible. That's how much is part of their national emissions, 1.69 carbon equivalent emissions per capita. If you look at England, they're doing much better, and that's because they've been trying to address the carbon footprint of healthcare for about over 20 years now. So they're responsible for 3% of their national carbon footprint and 0.44 per capita. If you look at Australia, we're much closer, even though we're much smaller population, we're much closer to the US than to England. And healthcare is responsible for 7% of our carbon footprint in Australia. We now have carbon interim emission reduction targets of 80% by 2030 and to be net zero by 2040. And if you're like me, I've just got no idea how we're going to achieve this. This is a study looking at the carbon footprint of healthcare in Australia, published in 2018. And what you'll see is 63% of the carbon footprint of healthcare is due to hospital and pharmaceuticals. You can see there is a small proportion there that's also research. And from the talk this morning from Melissa, there isn't anything there attributable to regenerative AI, and I wonder what the proportion of that would be here and how that might be growing rather than shrinking to net zero. So how will we achieve this? Well, as I said, I don't know, and we really don't have the research, the expertise or the awareness that we need to move to net zero, and I don't think we have that anywhere in the world. Can we identify carbon hotspots, which is what some of us, particularly in Sydney, have been trying to do, find which are the worst things and address those first? And there are less than 100 published studies looking at aspects of healthcare and measuring their carbon footprint, and I'll show you some of those. Should environmental footprint be part of our health technology assessment? We shouldn't allow any new drugs or other imaging or procedures unless we know that the carbon footprint is at least the same or less or zero. And I've been trying to get the carbon footprint for biologics for rheumatoid patients because there are a lot of drugs, they're all about the same, and they cost the same. So which one should I use? Well, I can't get that information currently. If we look at what we as clinicians, and I'm presuming some of you in the audience are, what can we control? What can we do ourselves to reduce it? And it's important to note that 40% currently of healthcare is buildings and other things that we don't currently control. And in the UK, that's now down to about 20%. So there's 60% where we can make a difference. If we look to England's NHS, how have they been trying to address this? And you can see there is a downward trend, and I've divided it into 3 parts. So in the first part, they adopted the Montreal Protocol because if you remember then we were worried about the ozone layer. So we got rid of CFC MDIs, which were ruining the ozone layer. And I'll talk about that again with what we replaced, which was not as bad, but nearly as bad for the environment. So that's how they reduced it then. And in the last little while, they've decarbonised the grid, and that's been responsible. Where my research has been is in this middle section, you can see that what's happened since really the early 2000s is that we've increased our healthcare, and it's not for good. We're doing too much stuff, and that's largely driven the emissions. Is we're doing too much healthcare. And if you look at an old report now from 2009 from the US, they estimated that 40% of healthcare is either of low value, so 30% is low value, and 10% is actually harmful. So that's 40% of healthcare that we can get rid of today if we had the will and the politicians would do something about it. And that's really due to overuse, overdiagnosis, overtreatment, using more expensive things when we can use cheaper things. So so I've done the graph on the right there. It's now 40% is the low value or harmful care. So maybe we could get rid of 40% of the carbon footprint. But the problem is we don't know if that's 40% of the carbon footprint, 80% or 20%, because we don't know the carbon footprint of most things that we do yet. And we're really lacking the expertise in people being able to do those assessments. I've done a short course, but I couldn't do it. I can't do the life cycle assessment that you need. You need engineers, you need people who understand how things move from country, how things are manufactured. So in my area, we have a lot of low-hanging fruit in terms of low-value care. So here's an example of shoulder ultrasound, a totally useless test, costing us millions of dollars. Here's low-value spine imaging. Most people with back pain don't need any imaging. And we're getting worse and worse. We're doing more CTs and more MRIs. But how much is of that? What's the carbon footprint of that? Well, recently, we now know what the carbon footprint is. This is a study done from Sydney looking just at one hospital and the carbon footprint of imaging. And what I've in the red circles, you can see what the carbon footprint is. And these authors tend to describe the carbon footprint in how far you would have to drive a new European car. And so for MRI, it's 145 kilometres. And you can see it's still high for CT at 75 or 6. And it's much lower for X-ray or ultrasound. So if I was a pragmatist, I'd say, okay, well, I don't care about the shoulder ultrasounds, but I do care about the MRIs and the CTs. And we just simply need to get rid of them. So how can we know whether we're making a difference? This is a study led by Denise O'Connor, who's in the room, that we did with the federal government, where we just helped them with their usual quality improvement. And this was a study to try and reduce inappropriate musculoskeletal imaging. We identified the top 20% requesters of these low-value tests, which I've highlighted in yellow. And we were able to do a cluster factorial trial that I won't describe in great detail. But basically, we were able to reduce the number of imaging requests by 47,000. So I can put a monetary amount on there, which I won't, because this was a quality improvement, not a cost-saving exercise. But we could also put the environmental, how much carbon did we save, and we're hoping that we'll get the information from the department to be able to calculate that. And that would be really useful because that could push people to do this more often. And we now know a little bit about pathology testing. We know that there's a lot of low-value pathology testing, and there's some data there showing that the differences between, for example, a CRP and an FBE. We replaced CFCs with, I I can't quite read that, hydrofluorocarbons, and unfortunately they have a high carbon footprint. And so now we have to totally get rid of them and go back to not using propellants for asthma. We know a lot of the problem in hospitals is our anaesthetics and nitrous oxide in particular, and we know that this is a huge problem, and more recently we know that nitrous oxide leaks. So not only is it an occupational health hazard, but that's a huge waste of carbon footprint. It's just not even going into the patient. So we need to get rid of nitrous oxide. My dentist recently told me they use it for children, and she was shocked that I would suggest we get rid of nitrous completely. We've tried to look in our area what the environmental footprint of healthcare for musculoskeletal diseases is, and there were 49 studies, but basically we know nothing. We know a lot about surgical waste, which is a small component of the carbon footprint, but we know almost nothing about what are our high carbon. We can, we predict it's probably joint replacement surgery, but we don't actually have the data. We have also recently done a systematic review on what have clinicians or health services done to reduce the carbon footprint. What's the evidence that their interventions are effective? And so we hoped that we'd find lots of evidence in the literature. And so our primary outcome were emissions. And we actually found 21 studies, not a single RCT. In fact, all but one were single-arm before-after studies, and one was a single study time series. And most of it in blue were for reducing anaesthetics, particularly desflurane and sevoflurane, which have a high carbon footprint. And in some hospitals in Australia, they've completely removed those. I mean, in other hospitals, I'm told, we couldn't possibly, we need them. Some of it is about waste and recycling, and very few studies otherwise. Most of the interventions have been educational, and the other parts have been changing the environment, so changing how we order things, not allowing, reducing the flow in anaesthetics, not allowing people to do certain things. And so most of the studies, all except one, showed a benefit, but of course it's very low certainty evidence because of the study design. So we need to do much better here. Finally, we now do have a national health and climate strategy, and I won't talk about this in any detail because of our third speaker. Just to highlight that the second objective is to actually become net zero healthcare with those targets that I showed you before. And there is something in there about getting rid of both nitrous oxide and fluorocarbon MDIs. We now have a response, so there has been, since just this month, a committee set up to try and action the strategy, and I've got a couple of quotes there from Anne Duggan recognising the importance of the need to do this. We can get some information, but I've read this report and it sounds lovely, but there's no practical information in there, and a lot of things are done at a hospital level, and I think we need to do much better in terms of the research that we do in this area. Finally, a plug for Doctors for the Environment. If you can't do research or any of those things, you could at least advocate and join the DEA, and that's the link. They've got some great resources, including making meetings green, and how we can advocate for net zero new buildings of healthcare. Their latest campaign is to get rid of fossil fuels, and I'd urge you to speak to everyone you can think of, talk to your local member. We must get rid of fossil fuels if we're going to get anywhere near net zero healthcare. And if you want to know anything about what we do, Wiser Healthcare and an offshoot Wiser Carbon Neutral there, and thank you to those people on the slides for letting me borrow their slides. Thank you very much.